I'm Wei Bing, a neonatologist from Singapore General Hospital. And I'm here to introduce Prof. Erwin Khoo. It gives me great pleasure to introduce him. He's a practicing pediatrician and bioethicist at IMU University and a research fellow in the Department of Global Health and Social Medicine at Harvard Medical School. He also chairs the Malaysian Paediatric Association's Bioethics Task Force and serves on the executive committee on the Academy of Medicine of Malaysia's College of Paediatrics and the Malaysian Paediatric Association. He's also a member of the Ethical Professional Practice Committee of the Academy of Medicine of Malaysia, and he sits on the editorial board of the BMC Pediatrics. Today he will be talking about advancing pediatric research ethics in Asia, imperatives, challenges, as well as strategies for achieving the SDGs, which are the Sustainable Development Goals. As we all know, Asia has unique challenges of high population density, inequality in the income, as well as rapid urbanization, and this places immense pressures on resources as well as public services. So advancing pediatric research in ethics is a cornerstone to address these disparities as well as to achieve the SDG goals. Prof. Khoo will be talking about three main aspects: risk stratification, child assent, as well as balancing research incentives with the need to protect child participants.
Thank you, Dr. Poon. My thanks to Roy and Mayok for the invitation. Really very honored to be here with all the brilliant speakers and all the brilliant comments from the guests and delegates. I think really wonderful to have all of you here. It's really terrifying to speak after very great speakers and very great comments. I hope to do justice in my talk right now. Just a bit of disclosure, I work in a private for-profit medical school. I own a private healthcare practice. I get paid by pharmaceutical companies to give talks. I am a medical advisor for Means Medica, got certain grants, few grants, and this talk is of my opinions, and some images are from Google and Getty Images as well. This is the structure of my talks. I'll talk about SDGs, the progress and challenges in Asia, why advancing pediatric research ethics in Asia can help. I'll talk to you about challenges of pediatric research and perhaps suggest some recommendations of how we can move pediatric research in Asia forward. And let me convince you why it's important to do that. The SDG were conceived in United Nations conference in Brazil in 2012. Imagine, it has been more than 12 years right now. It is set up because we want to tackle challenges that's facing our planet. It's based on universal goals that we need to achieve by year 2030. Among the 232 SDGs indicators, 35 of them are child-focused indicators, 17 of which UNICEF are either a custodian or co-custodian to it. In 30 years, between 2019 and 1990, under 5 mortality has decreased by 59%. But millions of children still die from preventable deaths. Let's take a look at Sub-Saharan Africa and Asia, which together accounted for more than 80% of this death, equivalent to 5.2 million deaths for less than 30 years. Bear in mind that children in this continent comprise only 51% of the global population of this age group, but yet we still have more than 80% of children dying in this region. Africa consistently has the highest number of countries not projected to meet SDGs, followed by Asia. At this rate of progress, we can only meet our SDGs in 2062 rather than 2030. We are 32 years off the target. This is Asia. Asia has high population density and diverse ethnic and cultural backgrounds, making it challenging to have one fitting all solution. This high population density strains resources, infrastructure, and public services. The world reached a population of 8 billion people in November 2022, and most of them, these populations are in Asia. More than half of the world's population are in Asia. I love Singapore. In fact, as a Malaysian, I love Singapore too much. I particularly love Singapore dollar compared to Malaysian ringgit. There are significant income inequality in Asia. Singapore, Japan, and South Korea is doing so wonderful. The university is so brilliant and so nice. Everybody in the room is just have great IQs and talk so well and being such respectable and admirable person. Then we have many least developed countries in Asia as well. Afghanistan, Nepal, for example. This income inequality affects access to education, healthcare, and economic opportunities, hindering progress towards several SDGs. Many Asian countries are experiencing rapid urbanizations as well. This leads to lack of basic infrastructure, such as clean water, reliable energy, and which are essential for achieving SDGs. Asia is also highly vulnerable to climate change. This includes rising sea levels, extreme weather events, and natural disasters like earthquakes and typhoons. Industrialization leads to severe pollution and environmental degradation, impact health and sustainable development. Asia faces a high risk of infectious diseases or emerging infectious diseases. We have tuberculosis, malaria, dengue, not so much in Singapore perhaps, but it strains healthcare systems across Asia. This article by Cocker in 2011 explains why Southeast Asia in particular is at risk of emerging infectious diseases. This may be attributed to, quote, population growth and movement, urbanization, changes in food production, agriculture and land use, water and sanitization that affects of health system through generation of drug resistance. Then we have political instability. Conflicts, governance issues in certain Asian countries creates barrier to development and hinder the implementation of SDGs. Issues related to human rights, gender equality, and social inclusions need to be addressed so that, ladies and gentlemen, no one is left behind when we achieve the SDGs. Of course, then, the disparities in access to quality education. Again, perhaps not seen much in Singapore. This inequality, particularly for girls and marginalized groups, limits opportunities for social and economic advancements. So, ladies and gentlemen, you may ask me then, what am I talking about? How is this important? How can we make a difference? Let me convince you that advancing pediatric research in Asia could alleviate these challenges. Let me explain. This is a very busy slide, but just bear with me. As healthcare professionals or researchers, you and I are trained to offer multilingual options for inclusive communication. Number two, you and I are trained to simplify forms and provide assistance for enhanced understanding. Number three, you and I are trained to utilize universal symbols and visual aids for clearer interpretation or clearer understanding of talking to patients. You and I are trained to implement interactive educational tools. We write papers on it, we publish manuscripts on it to engage learners. You and I are trained as advocates, as ethicists, to ask difficult questions Sometimes the difficult questions are so difficult that we end up in jail in certain countries. You and I are trained to provide clear answers when we can't, where most can't. You and I are trained to develop patient-friendly information materials for easy comprehension. You and I are trained to use technology to enhance patient engagement. And you and I are trained to regularly assess patients' understanding or our colleagues' understanding so that they have, quote-unquote, shared decision-making or personalized decision-making. All these instances of advancing pediatric research improve health literacy. For example, at Harvard, our pediatric research promotes transparency and community engagement. It demonstrates trustworthiness in health intervention and improves the inclusivity of health services for all children, including those who are marginalized. By ensuring that research adheres to ethical standards, we promote social inclusion and equity. Riton and colleagues, through tailored interventions, identified the health needs of children in rapidly urbanizing areas and developed strategies to provide adequate healthcare services, reduce child mortality, and improve overall child health in urban slums. To my colleagues in India who have been doing so much of wonderful things over the past decades, this is one example. Scientists used to study air pollution and monsoons separately. The India's National Family Health Survey, in collaboration with data from NASA, demonstrated that these two problems might be connected and should be studied together, highlighting that the significant association of monsoon seasons with health outcomes among young children in India. And through these collaborations, George and colleagues found that environmental factors linked to poor health outcomes because of high toxicity cooking oil, open defecation, and household smoking, particularly in northeast of India, due to factors that expose negative correlations of pollutions. This is an example of, ladies and gentlemen, of how pediatric research help identify barriers to health and develop scalable, cost-effective interventions that are accessible to all children. Advancing pediatric research can also lead to development of vaccines that are prevalent in Asia. Take, for example, the malaria vaccine against Plasmodium falciparum, the deadliest malaria parasite globally, most prevalent in Africa. This vaccine reached about 2 million African population in Ghana, Kenya, Malawi, through the malaria vaccine implementation program between year 2019 to 2023. Today, we yearn for close collaboration among countries in Southeast Asia to develop vaccines that targets Plasmodium vivax. But of course, here comes the talk. There are challenges. Firstly, with off-label prescription, I think we spoke about it briefly this morning. Off-label prescriptions in children is real. Most of you are pediatricians or nurses over here. And at least we know that at least 1/3 of hospitalized children and up to 90% of neonates in intensive care receive off-label prescriptions. The problem lies in the shortage of pediatric research that creates this ethical dilemma where doctors need to choose and decide whether to treat children with potentially beneficial medicine or treat them with medicine based on adult studies or perhaps his or her experience in children. No doubt, many children benefited from this off-label prescription. But studies have shown that some children experience harm, either because the dose was ineffective or because it was toxic. More importantly, ladies and gentlemen, the widespread use of off-label prescription further diminishes the incentives to finance pediatric research on drugs that are already approved for use in adults. Number two, compared to adults, children generally represent a smaller market for commercial sponsors of research. We were just talking about, with Julian, who isn't here now, about how or when or how or why we should get this conference sponsored by pharmaceutical companies. Maybe. The commercial values of drugs for children, especially for rare disease, may not be enough to offset the cost of developing them. Even for relatively common childhood conditions, the number of potential research participants are smaller and thus require more study sites and additional costs for coordination. In addition, more time is often required per patient to complete study procedures compared to adults, and it's more expensive compared to adults. And we often need specialized lab studies and require small volume of biological samples. Even taking assent and consent from children is way difficult from adults. Third, companies are often cautious with clinical, ethical, and regulatory requirements for pediatric studies. Companies are often concerned about financial and public relation consequences. What if the study goes wrong? What if the adverse effects of the drug that they were testing goes wrong? Some of these are real, and some of these ethical obligations have made research involving children more burdensome in certain aspects of research compared to the adults. Isn't it funny to think about how a CEO of a gaming company who produce games, violent games such as GTA, Sam Hauser, for example, earns millions of dollars with these violent, gory games that they produce. But yet, we frown upon a team of experts who develop vaccines or malaria vaccines who get compensated millions of dollars where they develop the vaccines. But it is okay for CEOs of gaming companies to earn billions. You might be familiar with this slide. The stratification of research risk in pediatric studies is problematic too, due to its vagueness and variability in interpretation. For example, there is significant variation in how IRBs assess risk. For instance, allergy skin testing was rated differently by various IRBs chairs regarding its level of risk. This is shown in many studies. Some procedures are considered minimal risk by some but not by others. Then, ethical pediatric research often requires genuine uncertainty, quote unquote, among clinicians about their treatment. If evidence clearly favors one treatment, the trial should not proceed. This clinical equipoise research must pursue valid clinical questions with a genuine belief to the quote unquote unknown answers. This is a challenge. Then also, the question begs, should research always requires informed consent? What about in learning healthcare systems and comparative effectiveness trial? It's now about decades has passed since the support trial has been conducted. And yet, ethicists still have many opinions on what is considered the right way forward. Sometimes we ought to balance patients' autonomy with the societal needs for medical knowledge. Then there is a challenge of obtaining assent, ladies and gentlemen. We know that assent is the affirmative agreement from a child who may not have the legal capacity to provide full consent. It serves as a process, not just a form. It engages with children. It respects children's preferences, choices, and agency. It ensures that children understand the research to the extent of their developmental capabilities. And here lies the problem. The problem is we know that only when at 7 years old, children shows less egocentrism. After that, they are able to consider perspective of others and comprehend consequences. I was just talking to Julian about our kids, who is now 3 and 5 years old. They have real dilemma in knowing about the perspective of others, of sharing toys, for example, is real difficult. We also know that children less than 9 lacks the cognitive capacity to provide meaningful assent. Children less than 11 lacks the intellectual capacity or tend to defer to authority and self-determination. And only at the age of 15, children only then starts to demonstrate competency comparable of that adults. Wendler and Shah suggest that threshold for assent be fixed at the age of 14 until instruments are developed. At the local level, the College of Paediatrics of Malaysia proposed that it should be at least 9 years of age instead of the traditional 7 years of old. Asia has about more than 2,300 languages spoken. More than 2/3 of the total language spoken in the world. In one region alone, West Papua of Indonesia speaks more than 270 languages. The Greenberg's Diversity Index shows that Asia and Africa, again, these two continents, has the highest ranges of people speaking in different languages. This index shows the probability that 2 people selected from the population at random will have 2 different mother tongues. It ranges from 0, everyone has the same mother tongue, to 1, no 2 people have the same mother tongue. The next challenges is that pediatric research needs to navigate a predominantly patriarchal remnants of feudalistic and conservative Asian society. It involves, like what was discussed this morning, a balance between the values of dignity, agency, family integrity, considering the aspects of the collective agency of people. We need to talk about respect to family connections and social relationship rather than individual choices. Also, children's rights and interests are viewed as inseparable from their parents. I was deciding whether to put up this slide after Daniel's talk. But Daniel spoke about how it is important for parents to play an important role in constructing their children's decision, may or may not. Seeking a child's affirmative assent is an independent activity. It may be culturally inappropriate and even assaulting to seek the child's assent alone, especially if parents have already given their permission. A child's dissent may result in guilt, resentment, and interfamilial conflict. So we ask, can parents be unduly influenced by the incentives? Can the incentives of the research result in exploitation of the child? What is excessive? What forms of incentives are preferable? Does the parents influence decision-making of the child's preference? Ideally, we want participants to be motivated by altruism. We want children to be connected with the goals of the research when seeking assent. In reality, parents volunteer their children in research for many, many morally permissible reasons. This includes things such as perceived health benefits or inducements such as free medical care or medications. Or perhaps the parents want their child to be in the research because of compensated payments. Or the parents does not want to insult the doctor who asks for a consent for the child to participate in the research. So ladies and gentlemen, human motivation, I feel, is complex. As described by Maslow in his motivation theory, it is often opaque and difficult to predict. As Lenny Ross puts it, if some parents are willing to expose their child to take some risk to instill values by perhaps, for example, volunteering in community service, why should not they be allowed to enroll their children in research study for their children to both serve science and earn incentives? Incentives can contribute to positive impact on child health, especially in the underprivileged, and the incentive is not considered undue influence on a parent, and if the risks are minimal. So here's my conclusion. Here are my suggestions and a local level strategy. Perhaps can we emphasize that pediatric research procedure are often dynamic. It changes across time. It changes across culture. For example, whether children's assent or parents' permission should be sought first may depend on cultural norms, maybe depend on family facilitated and collective decision making. For example, we need to provide proactive language accessibility, verbal or non-verbal, and propose the flexibility of minimum age threshold. Perhaps can we support, like we talked this morning, local empirical research that highlights the importance in respecting children's agency while navigating Asia's cultural complexities? Perhaps can we ensure that experts are involved in ethics committee as early as possible? These experts should be in child health, for example. At national level, can we implement policies that offer incentives for pediatric research, such as tax relief, subsidies, or grants from government or regulatory agencies? Can we utilize technology, such as telemedicine, or electronic health records, and mobile health applications to reduce time, to reduce costs to pediatric research? Can we educate or encourage transparency and open communication with stakeholders to provide consultancy service to guide industries, commercial company stakeholders to say that pediatric research process, although tedious, are worthwhile? At the local and national level, we have published position statements and formed a task force to move the bioethics agenda in Malaysia forward. Of course, these are small baby steps compared to Singapore again. So, my dear friends, at a global level, can we collaborate? Can we talk to each other and expand the potential market of participants pool, for example? I really like the survey that was administered this morning. Perhaps we can do a multinational studies in regards to opinions on the research. To answer the question, can we establish pediatric research and ethics network, like you have already done, to pool resources and share data, thus reducing the individual burden on each sponsor? Perhaps you can streamline protocols to minimize costs and logistical burdens, and research focus on off-label prescriptions such as anti-infective and nervous systems prescriptions. So, ladies and gentlemen, we have huge obligations here. We have obligations to advance pediatric research to help achieve the SDGs in Asia, perhaps not by 2030, maybe 2040, just because involving children in research is really important, although burdensome. It has a crucial role to improve health literacy, promote health equity, and sponsor targeted health intervention. With that, thank you very much.